First, I would like to thank the organizers for allowing me to present this topic of pancreatic cancer, the radiology, what the surgeon should know. I have nothing to disclose. If you find the topic has been very specific, it is from the point of view of a surgeon. In most of our institute, we will manage pancreatic adenocarcinoma by a multidisciplinary team. Each member of this multidisciplinary team will have their own perspectives when they address the imaging of a pancreatic cancer. For example, a radiologist and a medical gastroenterologist will be more interested in diagnosing it accurately, whereas an oncologist would try to assess the staging and the resectability more accurately. However, if we take from the perspective of a surgeon, they shoulder another burden. That is, surgery still remains the only curative option. So anything less than R0 resection that is offered to the patient is not going to benefit the patient. In that way, the surgeon also is burdened with the duty of performing a surgery which has significant morbidity associated with it. So what a surgeon really wants to know from an imaging? Firstly, the diagnosis of cancer. Second, followed by the staging, which includes broadly the resectability status as well as metastatic workup. The surgeon would also like to know any factors that could have an impact on the intraoperative steps or the postoperative outcomes. This is a table which summarizes the various imaging modalities that are currently practiced. At the top, we have a transabdominal ultrasound, which is more of an initial investigation but doesn't add much of a value in the workup. Cross-sectional imaging such as CT and MRI are required in assessing these patients. In a CT, a pancreatic adenocarcinoma typically looks like a hypoattenuating lesion when compared to the normal pancreatic parenchyma. However, it does miss out on isoattenuating lesions and can miss out on small hepatic lesions. These are covered by MRI. EUS of late has become increasingly used in identification, and with the added advantage of getting an histological diagnosis is being performed more widely. FDG PET scan can also add value in terms of detecting otherwise undetectable mets in a routine cross-sectional imaging. Having said all these, surgeons still prefer a good quality CT with the pancreatic protocol, given its good resolution and multiple reconstruction planes that are available, lesser intra-observer variation, and to be frank, as surgeons, CT resembles more the familiar anatomy that we encounter during the surgery. So it is easily understandable that surgeons can relate to the CT. This is the protocol that is laid by American Journal of Radiology regarding the technical details as to how a pancreatic protocol needs to be performed. The slices needs to be less than 1 mm, neutral oral contrast needs to be given. The most important thing is regarding the phase. So the pancreatic parenchymal phase or the late arterial phase should be part of the protocol apart from the regular arterial portal venous phase. So this is a classical pancreatic adenocarcinoma involving the neck of the pancreas abutting the splenic vein. We can find it is hypoattenuating when compared to the normal parenchyma, as well as an upstream pancreatic duct dilatation is seen. This is the pancreatic parenchymal phase. So we can distinguish the lesion quite clearly here, whereas the one on the right side shows the portal venous phase where the distinction is not so great. Sometimes we might have very small lesions or isoattenuating lesions wherein we might have to dig in further to identify these lesions. So they can be made out if there is an upper cutoff of MPD, there is distal pancreatic atrophy, a double duct sign. So another image to showcase this importance, how we can find no lesion which is demonstrated in the CT. However, we can find an abrupt cutoff of MPD. The same lesion was also not picked up in the MRI sequences, but was picked up in EUS and a biopsy confirmed an adenocarcinoma. Having confirmed the diagnosis of adenocarcinoma, next comes the resectability. Predominantly, it deals with the planes the tumor has with respect to the venous system as well as with the arterial system. We have various criteria, but the most common followed criteria is the NCCN criteria. I am not going to go into detail, but predominantly venous is very simple. Resectable, no involvement. Advanced is unreconstructable SMV portal vein disease. Anything in between becomes borderline. With respect to artery, again clear plane, resectable, unresectable, anything greater than 180 degrees or encasement or distortion. Again, representative images, we can find the lesion in the uncinate process of pancreas, which is quite away from the SMA. In this arterial phase, we can find again this lesion is quite away, with involving only it is abetting only the normal pancreas. Whereas in the locally advanced, we can find that SMA is completely surrounded by the tumor. In fact, in the constructed coronal images, we can find even the branches of SMA are involved. These make them a locally advanced disease. Coming to borderline, we can find in the arterial part of the borderline pancreatic cancer, the abutment is less than 180 degrees. With the SMA, same here. Here, there is a tumor which is abetting the common hepatic artery, but there is no encasement. So, all these will come under borderline resectable pancreatic cancer. Coming to venous, we can have anything from abutment, encasement to something like this, where the portal vein itself is distorted. This is a typical teardrop sign, which more or less indicates a portal vein involvement. So, after resectability, we would like to assess the metastatic part. The liver MRI has a generally better detection rate when compared to CT, especially with small lesions. PET scan again can add value. Just to demonstrate how MRI helps, the two lesions which are not seen in the classical CT are picked up with MRI with contrast. Coming to lymph nodal evaluation, with more neoadjuvant chemotherapy being used, an accurate assessment of lymph nodal metastasis is important to assess the response to neoadjuvant chemotherapy. Generally, we think in terms of size greater than 1 centimeter, but however, of late we have started assessing the morphology, and this is a very good paper which was published in World Journal of Surgical Oncology, which showed that the morphology with respect to the lymph node, if it is an inhomogeneous type, the rightmost type, then the possibility of lymph node metastasis specificity is around 94% and positive predictive value is 91.7%. Having said all these factors, it is still a variable inter-observer detection rates. So, this is a very good paper I thought we should know, in which 77 observers across the world, including radiologists and surgeons, were asked to evaluate 30 patients' radiology, and this is how they are classified. You can see there are a lot of variations. So, for example, patient number 18, there were a group of reviewers who had termed it resectable, but there were a group of reviewers who were also termed it as unresectable. So, the management itself will change. They might be due to difference in the guidelines that they follow, it might be due to the difference in the institute protocol, it might be due to the experience that the surgeon has, but whatever reason, still it is not uniform. Graph again depicting the same thing. Anything green shows good agreement, red is disagreement. You can find the entire chart is more yellowish red rather than greenish. So, why I wanted to show this study was, it is very important as surgeons we ourselves read the CT and assess the resectability so that we don't rely on another radiological report. Okay, having said that, suppose we have a classical pancreatic adenoid adenocarcinoma, 2 centimeter lesion, clinical scenario clearly fits in, resectable, no evidence of metastasis, plus or minus EUS FNB. Are we set to go? Is this information sufficient? I think not. As surgeons, when we are going to plan, especially in the era of minimally invasive surgery, it is very important for us to identify the vascular anatomy precisely before going ahead with surgery. The common variations that we all look for is the replaced right hepatic artery, one which is shown above, and the celiac arteriostosis shown below. Yes, in both the scenarios, we will have to be prepared for other kinds of reconstruction and maneuvers. But I also believe surgeons as such, we should deal with the normal anatomy that is seen in these patients. For example, this is a recent study published in 2023, where they just showed even fine arteries like AIPDA, PIPDA, ASPDA, PSPDA, all those can be detected with a sensitivity of almost 90% to 100%. So, we do have the information, it is just the eyes don't see what the mind doesn't want to know. So, it is for us to identify these arteries and be prepared better when we are dealing with such a patient. Again, just to highlight few examples, the gastroduodenal artery, which we are all interested in doing a pancreatic duodenectomy, origin course relatively stable, but we also know there are variations that are possible. Say for example, if this artery is going to course anterior to the common bile duct or to the right of the common bile duct, there is a possibility of injuring this artery when doing the hepatoduodenal ligament dissection. Suppose we have the PSPDA, which is going to occur very, very close, and when we are trying to dissect the GDA proximally, we might injure it and there might be an inadvertent bleeding, which we might find it difficult to control in a minimally invasive setup. So just to show how the PSPDA is arising very close to its origin. So this is likely to be injured if you don't take care of it in a preoperative radiology. Again, IPDA, I just like to show here nearly 14% of individuals had an inferior pancreaticoduodenal artery arising from a common trunk, the pancreaticoduodenal artery. So what it means is the jejunal artery and the IPDA came from the same trunk. If we don't know this, we might try to ligate the PDJ instead of an IPDA, which can lead to ischemia of the jejunum, therein have negative impact on the postoperative outcomes. So radiology shows this as SMA, this is the PDGA. We can see the first jejunal artery and the IPDA coming out after the PDGA. Similarly, with the dorsal pancreatic artery, it can arise from the common hepatic artery or the splenic artery. It can have branching throughout the pancreas. Again, anatomy can help us preoperatively. We can decide to ligate the DPA before even going for a pancreatic net transection, or in cases of a distal pancreatectomy, again, we can be little more prepared as to where we can transect the pancreas. Similarly, with arterial, venous system also has to be studied properly. Special importance to gastrocolic trunk of Henle, the first jejunal vein, and as well as the portal vein tributaries. Even with all this information, there are few gray areas in imaging pancreas, especially with early detection of pancreatic cancer, differentiating from benign mimickers. In the background of chronic pancreatitis, how reliable is the CT to predict malignancy? Assessing the response to neoadjuvant chemotherapy still is an Achilles heel. These are two images which I just wanted to put on the right side. The one above is the pre-NACT and the one below is the post-NACT. We can see how much it is abating, but we don't see any remarkable difference between the two. But after the Whipple's procedure, it is R0 resection and a good tumor response. Sometimes we might need also know what is the prediction of fistula risk preoperatively so that we can talk to the patient. For all these gray areas, in the last decade, we have started looking at radiomix to help us. So basically, all these data is pulled in, it is fed. There is a radiologist who does the segmentation part, pre-processing, and then feeds it into the system. By means of machine learning, the features are extracted and a model is built, after which the model is then validated further. So, with respect to the post-NACT, we have radiomics. With respect to prediction of fistula, that's something called as RAD-FRS. We have almost 3-4 studies which have come out, quite promising. But still, it is some way to go, because all these data that is being fed in is by a human. I already told you there is an intra-observer variation that still exists in interpreting resectability as well as the morphological characters of a pancreatic tumor. So how much it is going to be reliable, only time has to tell. There is also heterogeneity of patient data, and clinical adoption of these models is going to take some time for us to rely on it. So take home message, pancreatic protocol CT remains the preferred choice of imaging. Other imaging such as MRI, EUS and PET-CT can complement the baseline CT. As a surgeon, we should have our own checklist and should ensure that we go through the entire checklist every time, especially the vascular pattern. Radiomix is still evolving. So for surgeons, practice reading CTs to help in making surgical outcomes better. Thank you.
Any questions from the audience?
This is not a question, it's a comment. I work in a private hospital setup. Most of the patients who are referred to me with either an ampullary or a head of the pancreas cancer come to me today with an MRI and an MRCP. Because most of the medical gastroenterologists and general physicians have come into their head that MRI is better than CT for pancreas. And invariably, most of our radiologists, CMC is an exception where you have radiologists who specialize in GI, specialize in neuro, but as most of the radiologists in private practice see from the head to the toe. So their interpretations of MRI, they will write portal vein invaded. I have read reports where they say portal vein free, SMA invaded. See, anatomically it's very difficult for portal vein to be free and SMA to be invaded. The SMA lies to the left of the portal vein. So the tumor has to go through the portal, unless the tumor is arising in the body and infiltrating directly into the SMA. From the uncinate process or head, going past the portal vein without invading it into the artery is almost an impossible position. But they will write reports like this. So I have a protocol. And I advise every young surgeon who is going to do a Whipple's in this room, because the seniors probably already follow it. If they come with a MRI, or they come with a CT without a vascular recon or without a good arterial phase where you can make out the arteries, ask them to have a repeat CT at your center with a vascular reconstruction. And please, do this before the patients are stented. Once they are stented, the stent artifacts will make your arterial reading and everything a little more difficult because they will give artifacts. So do it before the stenting. And don't hesitate. Insist that your radiologist gives you a vascular reconstruction like he showed. And you will often find that there are tremendous things which you don't want to find on the table. Though we all say look for it on the table, we will do some injury or other. We have done an analysis of over 600 CTs in the last 2 years as one of our thesis, and we did a vascular reconstruction. All 20% of the common hepatic artery arises from the right, from the superior mesenteric artery, not from the celiac trunk. If you look for it in the celiac trunk area, there is no artery there. So these, there are a lot of many arterial variations. I was operating at a workshop where I was doing a radical gastrectomy, and I had a huge gastric artery, left gastric artery, and everybody asked why you are not clipping it. I said it's so big that I don't know why it's so big. So let me do a little more dissection, and I dissected more. There was no common hepatic artery. There was no artery from the SMA in the hepatoid ligament. There was no artery. The only artery supplying the liver came from the left gastric. If I cut the left gastric in the total gastrectomy, the liver would have become ischemic. So please get a CT, a contrast CT with a vascular reconstruction before you step into a Whipple or a liver resection. These two need it mandatorily.
Thank you, sir, for the comments. Any more questions or comments? Otherwise, we'll go on to the next topic. The next topic is will also be presented by Dr. Gautam. The topic that's given is preoperative biliary drainage before pancreatic duodenectomy.
Thank you. I'm presenting on behalf of Dr. Patta sir, who was not able to make it today. So the topic is preoperative biliary drainage before pancreatic duodenectomy. Nothing to disclose. So the obstructive jaundice that we encounter has significant pathophysiological consequences. It is basically because of two factors. One, the bile that is being produced doesn't reach the intestine. Second, the bile that is produced stays in the biliary system with an increased pressure. So when it doesn't reach the intestine, it has consequences like lack of absorption of fat-soluble vitamins, fats itself, the integrity of intestinal mucosa is lost. So there is likelihood of translocation of bacteria as well as bile salts or endotoxins getting absorbed across an intact wall, which can lead further to endotoxemia. Similarly, the bile that is stagnant within the biliary system is going to gradually increase, and under pressure is going to reflect back into the blood. And this can lead to other cardiac issues, renal dysfunction where the bile salts are known to cause tubular necrosis. So with this background, the concept of preoperative biliary drainage started some 3 decades back. It is very simple concept where the surgeons and the anesthetist believe it is one path in which we are going to optimize the physiology before taking up the patient for a major surgery. So they felt it can lead to improved coagulation status, improved wound healing. The anesthetist need not be worried about drug-to-drug interaction. The inflammatory state that is caused by the endotoxemia can be corrected. Malnourishment as well as renal dysfunction can also be optimized better. So what started initially was preoperative biliary drainage was advised in patients who are having any kind of hyperbilirubinemia, acute cholangitis, intractable pruritus, renal dysfunction, malnutrition, and any possible delay in surgery. In the last 2 decades, we have also come across borderline resectable or locally advanced metastatic requiring chemotherapies for which biliary drainage is required. Of these two are little subjective. I will be talking about them little in detail later. But over the last 2 to 3 decades, what we have realized is the preoperative biliary drainage does not show any improvement in surgical outcomes. In fact, has negative impact, especially in the form of increased surgical site infection. So once we started realizing it, now comes the balancing act. We initially thought it would help us. Now we started finding there are complications, there are issues, it is not helping. So why it was not helping? Yes, one possible hypothesis is the disruption of the sphincter of OD barrier, which leads to increased colonization of the biliary system by the enteric organisms, which in later during surgery causes post-operative infective complications. The procedure itself, like an endoscopic biliary stenting, can lead to cholangitis, pancreatitis, and any complication that arises after a preoperative biliary drainage is likely to lead to a delay in the definitive surgery. So these are the risks that we are likely to encounter when you are planning for a preoperative biliary drainage. There have been numerous studies. I just started with this landmark paper called the DROP trial, which was published in 2010 from the Dutch study group, which analyzed nearly 200 patients divided into direct surgery first and preoperative biliary drainage followed by surgery. They didn't show any difference in the post-operative outcomes in terms of fistula, in terms of major complications, hospital stay, anything. Subsequently, there have been numerous studies. I didn't want to go in detail, so I just put a systemic review and meta-analysis that was published in earlier this year, which had more than 5,000 patients studied, and they didn't show any difference in terms of pancreatic fistula rates with or without preoperative drainage. There was a slightly decreased incidence of bile leak when preoperative drainage was performed. No difference in intra-abdominal infection, slightly increased incidence of surgical site infection. There was no difference in hospital stay or sepsis. This is one of the studies which showed about how it is going to have an impact on long-term survival. The chart here, Kaplan-Meier, which had all the population of the put together, didn't show any difference in patients who had a preoperative biliary drainage versus no preoperative biliary drainage. So basically there was no difference. Regarding the hypothesis of biliary system getting contaminated, this was a very good article in which nearly 300 patients were studied who had undergone preoperative drainage, and nearly 2/3 had positive bile culture, and they were significantly associated with organ space infection when compared to the population which didn't have a bile positive culture. Again, regarding the organisms that were isolated as well, whenever the preoperative drainage was performed, we are likely to encounter more polymicrobial organisms apart from the usual enteric. I just wanted to highlight these two, the fungus and Acinetobacter baumannii, which as surgeons we don't want our patients to have. They were significantly more in the preoperative biliary drainage when compared to the group which didn't have the preoperative biliary drainage. Even among the resistance pattern, nearly quarter population had resistance to piperacillin tazobactam, cephalosporin sulbactam, the commonly used antibiotics we used. And if not, levofloxacin had nearly 50% and oxacillin had nearly 2/3 resistance. So, preoperative drainage as such is going to have a negative bearing with respect to positive bile culture. It is going to lead to complication. It has also been shown to have harbor higher antibiotic resistant bacteria. So with this background, we should be careful in handling the bile also during surgery who have undergone preoperative drainage. So this was a study which showed how the bile exposure time during surgery increased the incidence of infective complications postoperatively. So having seen how preoperative biliary drainage has evolved over a period of 3 decades, there are 3 things that needed to be still addressed. One is the optimal bilirubin value. Second is the timing of surgery after drainage. And third is the type of drainage that we need to perform.
Could you tell the figures in milligrams, because most of us
Oh, okay.
micromoles.
So the drop trial, which had a cutoff of 250 micromole, actually talks about 14.6 milligram per deciliter. So patients who above this were excluded from the study itself. So the immediate outrage was, the limitation that was quoted was, this talked about, the drop trial talked about patients who had a lesser amount of bilirubin. So we did have studies later which showed higher bilirubin levels. So this is almost like 15, 255, 255, and 306 was around 18. So all these retrospective studies still showed that direct surgery was better or equal to patients who had undergone preoperative biliary drainage. This was again nice article published in HPB 2022 from the Dutch group, but not the pancreatic surgery group, which showed, irrespective of the value, more than 250 or less than 250, the complication rates were similar. So there is no point in draining them before surgery just for the sake of hyperbilirubinemia. The timing of surgery, generally it is a notion that once the biliary system is drained, the dysfunction, metabolic disorders and hepatic dysfunction takes 4 weeks to correct itself. So initial days, it was all 4 weeks. Even the drop trial had a 4 to 6 weeks of waiting period before patients were taken up for the surgery. However, we started realizing that by reducing the interval, one major thing is we can avoid more the PBD related complications. For example, an endoscopic stent getting blocked and percutaneous drain getting dislodged. So those complications can come down if we reduce this interval. Probably reducing the fibrosis which we might encounter intraoperatively, and also there might be an oncological advantage by doing the surgery earlier rather than waiting for 4 weeks. This is to just show how the liver function tests get normalized. Roughly around 15 to 17 days, that is the time they started dipping and the majority of the patients started normalizing. We can find how there was a dramatic dip in all the liver enzyme patterns. So this is a meta-analysis published this year, just 2 months back, which talked about the interval between the preoperative drainage and the surgery. So they did study in terms of 3 groups, keeping the cutoff as 2 weeks, 3 weeks and 4 weeks separately. What they found was, if the cutoff was 3 weeks or 4 weeks, there was no difference between the duration on the impact of postoperative outcomes. Whereas if the cutoff was taken as 2 weeks, that is after preoperative drainage, if the patient underwent surgery less than 2 weeks versus greater than 2 weeks, though the mortality was similar, the morbidity was slightly lower, the septic complications were lower as well as the operative time were lower. So this again, the study with all the meta-analysis and a good article has re-emphasized early surgery after a preoperative drainage might be more helpful than delaying the surgery. Coming to the techniques of drainage, endoscopic biliary drainage is the most commonly preferred, more physiological. We can either do a plastic or a metal stent, uncovered, partially covered, Nowadays we also have EUS guided choledochoduodenostomy in suitable patients being done. Percutaneous biliary drainage is generally reserved where there is a failed ERCP or a moribund procedure. We do have an issue of quality of life with an external bag, loss of bile, and then possibility of tube disgorgement. This is a meta-analysis by the Windsor group, which tried to find out the impact of the type of drainage with respect to the complication rates. They try to do individual, all the four, no biliary drainage, but preoperative drainage with plastic stent, with metal stent, and preoperative drainage with a percutaneous drainage. Among all these analyses, there was no difference. And there was no impact on the type of complication. This is an interesting article I just thought I should share, published in 2013, where they found there is an increasing incidence of endoscopic intervention for biliary drainage, but the proportion of patients who are undergoing percutaneous drainage still remains the same. So again, emphasizing that we prefer endoscopic drainage rather than percutaneous drainage. The same study showed that the patient is likely to undergo a endoscopic drainage if he or she visits a gastroenterologist first before visiting a surgeon. So thus, I would like to conclude, routine preoperative biliary drainage is not advisable, especially in a resectable patient. I believe that even the decision of a preoperative biliary drainage should be taken by the multidisciplinary team, which can balance the risk versus benefit. Where we have absolute indications which are clear, but relative indications is better to have the MDT in place. Hyperbilirubinemia, irrespective of level, alone should not be an indication for PBD. Early surgery has better outcomes, and endoscopic approach is preferred over percutaneous approach. Thank you.
Thank you, sir, for crisp and clear message. Any questions or comments from chairpersons before we go on to the audience?
I think yes, well done, Dr. Gautam. Both the presentation is very good, and the first one you explained the importance of the arterial anatomy that we should have, and in this, not necessarily we should jump on to do a drainage up front. Okay, you have to choose after good planning. Madam?
So I wanted to ask, in your own personal practice, what is your cutoff? Do you operate patients directly without pre-op drainage till 15, or like at what level do you do?
In our institute we don't see the bilirubin levels. Only indication is if there is a portal vein involvement, it comes into borderline, and we are planning for an upfront surgery, then we might consider an preoperative bilirubin.
So in all other cases you will
Upfront surgery.
And what kind of have you experienced this coagulopathy and sepsis, which is more than drained patients?
No, if they are presenting with cholangitis, that is different. But if it's just an hyperbilirubinemia, I don't see any difference in doing drainage versus upfront. Anyway, we are training the system. The idea is it should not increase the morbidity of the surgery. In our practice, it doesn't show that.
I think we are concentrating too much on the bilirubin. Please remember that liver is not defined only by the bilirubin. What is important is to take the serum albumin at the time of presentation. When the bilirubin crosses 15, invariably the serum albumin is 3.2, 3.4, well below what we would operate. We stent not as much for the hyperbilirubinemia as much as to improve the nutritional status of the patient. So I think the albumin, and none of these studies have actually concentrated on albumin. And none of these studies have actually concentrated on taking the group of patients who have bilirubin above 15, because that is the group that benefits maximum, because they will have a low albumin and a high bilirubin. And the SGPGI group has shown that with a high bilirubin, their blood transfusion rates were more, their bleeding was more. That question which he asked about coagulopathy, the SGPGI group has published a paper that the coagulopathy, the platelet dysfunction because of the higher bilirubin is there. So I think what we must understand is that it is not an isolated bilirubin you should look at. You should look at the entire liver function test. You see OTPT 150, 170, that is evidence even if there is no fever or chills of subclinical cholangitis. That patient requires drainage. Do a direct operation and you're going to get into trouble. So bilirubin alone is not a factor. It's the entire LFT and the entire how the patient looks. And then you decide whether to stent him or not to stent him. And usually we have found that 15 is a cutoff at which all the other liver functions are down, and we would always stent patients above 15 bilirubin. The way to stent them is to either use a short metal stent, but if they can't afford that, what we routinely do is to place 2 plastic stents. Now the single plastic stent has a high incidence of getting blocked and the patient coming even within 1 or 2 weeks with cholangitis. With 2 plastic stents, the bilirubin drops well faster and the patients don't get cholangitis. They actually last as long as a metal stent.
I'm going to take off where Dr. Ardhanari stopped. There is an animal study which was done very elegantly. They tied the bile duct and then they serially sacrificed the animals and studied the anatomy. The whole physiology is that the liver produces secretory IgA. This is a protective protein which prevents translocation of bacteria from the gut. Once the IgA has stopped, you're going to get translocation of bacteria into the lymph nodes, and it's sitting there in the lymph nodes when you're operating. So once you have drained the bile, which we are trying to estimate, and albumin, as Sir said, we have no way to find out how much is the bacterial load in the lymph nodes in the operative area. So this study actually showed that the lymph nodes were cultured post-operatively, animal study. And so about 2 weeks or so later, since the secretory IgA had coated the upper gut again, the bacterial load in the lymph nodes started going away. And we are using bilirubin as a surrogate marker of these complications. So probably neither bilirubin, of course, albumin is a surgical marker for good outcome. But bilirubin here is looking at being a surrogate for bacterial translocation because the IgA is absent in the mucosa. Thank you.